Great. Well, welcome everyone. Thank you for joining us today for our Innovative Discovery series. Before I introduce today's speaker, I want to go over a few of our standard housekeeping items. We continue to extend CME credits for our Tech Talks and ID series presentations. Information is distributed to those who register, including today's event. If you didn't register and you'd like to obtain CME credit, that's certainly possible. If you can just email Lisa Maturo. Her email address is lisa.m.maturo@christianacare.org. If you need us, I'd be happy to put Lisa's email in the chat if anyone needs that information. Just send me a message, or you can message Lisa directly. So also please mark your calendars for our upcoming sessions. On December 11th, our next ID series speakers will be Drs. Ann Kazak and Carissa M. Baker-Smith from Nemours, Drs. Monica Roshman and Susan Burkhoff from Christianacare, Dr. Julie McCullinaire from Westchester University. They'll be discussing community research exchange for COVID-19 themed project presentations. So that should be very interesting and timely. On December 3rd, our next Tech Talk speaker will be Kimberly Carlson, who's a senior clinical researcher at Cerner Corporation. And she'll be reviewing the Cerner Learning Health Network, which is an overview of HLN, Cerner Real World Data, and the Health Data Lab. So with that, it's now my distinct pleasure to introduce today's speaker, Dr. Jonathan Purtle. Dr. Purtle is an associate professor in the Department of Health Management Policy at Drexel University Dornsife School of Public Health. His research focuses on population-based approaches to mental health with a particular focus on the dissemination of evidence about mental health to state and local policymakers in the United States. Dr. Purtle is currently the PI of a Robert Johnson Foundation-funded study that's testing the effects of strategic frames about toxic stress on public and policymaker support for child development policies and stigma towards children and families. He's also co-director of a P50 project jointly funded by the National Institute of Mental Health and the National Institute on Drug Abuse that's using agent-based modeling to understand factors that influence research use in children's state mental health policymaking. He was PI of a R21 funded study that surveyed state legislators to understand their opinions about mental health and substance use issues and how they use evidence in decision making. Additionally, he's co-investigator of an R1 funded study by the National Institute on Minority Health and Health Disparities, which is assessing the mental health impacts of Hurricane Maria on island Puerto Ricans. In addition, he's co-investigator of an R1 study funded by the National Institute of Mental Health that is assessing the effects of public housing policy on HIV and STI risk. Dr. Purtle received his doctorate in health management policy from the Drexel University Dornsife School of Public Health. He holds a master's in sociology from, hopefully I'll get this right, Jonathan, you can let me know if I mess it up, from the Universiteit.
The University of Amsterdam. You can
I wanted to try to go for it. And a master's in public health from Drexel University. Dr. Purtle is a prolific author whose research has been published in numerous journals such as the Millbank Quarterly, Annals of Maternal Medicine, American Journal of Preventive Medicine, Annual Review of Public Health, Implementation Science, just to name a few. While I am biased, it is an honor to have him with us here today, and I think we're in for a real treat. So please join me in welcoming Dr. Jonathan Purtle.
Thanks so much, Kim. And thanks everybody for joining today. So I'm Jonathan, and I will talk today about kind of broadly my arc of research in this area of mental health policy, dissemination, and implementation research. And I think, I'm sure some of you focus on mental health issues, many of you probably don't. But I think, this presentation is really meant to be kind of illustrative of how to think about and study public policy in the space of dissemination and implementation research in health, which is a growing area. So my burning research question and the work that myself and other colleagues focus on is really this question of how we translate high quality, policy relevant mental health evidence into public policy. So it is, becoming codified in laws and implemented in policies and not just sitting on a shelf or really more accurately, sitting on a server. And I have found, I was kind of interested in this question for a while, but kind of struggled with how to think about conceptualizing, research designs and what to study and how to get funding for it and all of that. And I found that the field of D&I research, dissemination and implementation research, was a really good home for the sort of questions that I was really interested in asking. So when I got into the field and started looking around and saying, all right, there's this field of D&I research, I'm interested in policy, and I'm specifically interested in the dissemination side, and I'll talk more about that more concretely, what's the field looking like? And what I found was that the areas I were really interested in were quite understudied. So we have way more implementation research than dissemination research. And I'll unpack that and talk about distinctions between dissemination and implementation. And also I found that, most D&I research is at the clinical level, a little bit at the organizational level, and really just a teeny tiny bit at the policy level. This is largely just my subjective appraisal. But in terms of, the different levels, we looked at that empirically. Sorry, I have a young friend in the room. We reviewed all grants funded by NIH that were funded through the D&I program announcement between 2007 and 2014, looking really hard for any and all policy-focused projects. And the policy projects are that little dotted line out at the bottom. We just identified 12 funded projects in this 7-year period. And in reality, only 1 or 2 of these projects were really focused on public policy. The other ones we included, because we cast a wide net, were kind of thinking about policy in a peripheral way. But good news, I think, attention towards policy in the field of D&I has really increased. So Kimberly Hoagwood and colleagues replicated our search here. They found 10 additional policy projects in a 3-year period. So that's a marked increase. And also the William T. Grant Foundation, private philanthropy, has been funding a lot in the space of public policy and increasing the use of evidence in public policy and how to go about doing that. So the area is growing, which is great news. So I want to stop and kind of take a moment of thinking about context and policy D&I research. As I showed a couple of slides ago, D&I research is often really focused on clinical settings and how to get, oftentimes clinicians and direct healthcare service providers to do things differently. And that's not the thing that I'm really focused on. I'm focused on how to get policymakers to do things differently. And those things are write and support and introduce bills that are aligned with research evidence and are thus most likely to have the best impacts on population mental health. So just thinking about context, in a typical dissemination and implementation study, and I'd say a typical study is kind of clinically focused. You have your evidence-based treatment in the middle, which is something that's been proven to work in probably multiple randomized controlled trials. Your adopters are clinicians or organizational leaders, perhaps. And then we have these constructs of inner context. That's something, say, like the organizational culture or the climate in the organization around implementing the thing. And then policy is this vague kind of outer context factor that is acknowledged that it influences what goes on in clinical settings, but it's way out there. It's not the focal point. But when thinking about, levels of context in a policy-focused D&I study, all these things look a little bit different. So in the middle, it's probably not an evidence-based policy, given, that, you can't randomize people to different policy exposures most of the time. The best you can have is some sort of policy that's evidence-supported or evidence-aligned. The adopters are legislators and other elected officials, or people over on the executive branch of government side, administrative policymakers, agency heads, things of that nature. The inner context is kind of more social and more political. So the governor's agenda, legislature politics, things of that nature come into play in terms of what gets done. And then the outer context is no longer policy, because policy is the focal point. The outer context is public opinion, media coverage, and this much broader socio-political context that surrounds policy issues. And in our research, we've studied all these different levels and thought about different ways to study them in ways that are relevant to the research questions that we want to ask. So the rest of this presentation has 2 main parts, and it's a lopsided 2. So the next 75% of what I'm going to present is about this idea of policy dissemination research. So putting out some definitions and then giving a lot of examples from work of me and my colleagues illustrating what this looks like. And then the second part will be focused on policy implementation research, which is much more underdeveloped, I would say, at least in the field of dissemination and implementation research, than policy dissemination research. So what I'm about to present, I think it's focused on mental health, but it illustrates how to think about this idea of policy dissemination research and perhaps how to go about it. And I would also say, the focus here is on policy, but I think it's also illustrative of how to think about dissemination research more broadly. So even if you are focused on clinical audiences or organizational leaders, this kind of approach I'm going to lay out for dissemination research, I believe is relevant and could potentially be helpful. So what is dissemination research, and what is the difference between dissemination and implementation? So I went to I was a fellow in this NIMH-funded D&I kind of mentorship program. I went out to Washington University in St. Louis for 5 days to get immersed in this stuff and get all trained up. And the first day, there's the opening presentation. It's all about implementation. I raised my hand, and I'm like, I'm focused on dissemination. Like, what exactly is the difference between dissemination and implementation? And it was kind of crickets, which was surprising. It was really surprising that, people hadn't really thought concretely about what dissemination is. So I dug around, and there is a good definition of dissemination and how it's different than implementation. So dissemination research per NIH, and this is from their D&I program announcement, is a scientific study of the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. The intent is to understand how to best spread and sustain knowledge and the associated evidence-based interventions. So really, dissemination is, in a lot of words, a fancy word for communication. It is the spread of information. And I think the key distinction between, say, dissemination research and health communication research more broadly here, your target population, it's not people, lay individuals in the general public walking around on the street. It's people with their professional hats on, be it a policymaker hat or a clinician hat or an organizational leader hat, and that is your audience, and you're trying to change their knowledge as it relates to their professional capacities. And of course, you cannot divorce the person's kind of who they are outside the work world from who they are in the work world. But I think that's the key distinction in dissemination research. Your target population are people in the professional capacity, in a health context, and you're trying to figure out how to best communicate with them, spread information to change knowledge and attitudes and things of that nature. Whereas implementation is the use of strategies to adopt and integrate evidence-based health interventions and change practice patterns within a specific settings. So I read this as implementation. When we're talking about implementation outcomes, we're really talking more about changing behavior. Whereas dissemination research, we're more about changing knowledge and attitudes and kind of the precursors to those behavior changes we ultimately want to see. So instead of D&I, as it's often expressed, I think it's more of kind of a D-I, right? So if you disseminate information well, you change knowledge and attitude, you kind of cultivate a context among individuals that's a stage for effective implementation strategies and the behavior changes that you want to see. So next thing I want to present is what me and my colleagues have kind of called a staged approach for policy dissemination research, or data-driven dissemination, if you will. So I'm going to present 3 different types of studies, and all this kind of comes out post hoc from us trying to figure out the types of research questions we need to ask in what sequence to generate what we think is really meaningful knowledge. So this is us just trying to figure it out, and after we start to kind of figure it out, go backwards and kind of put the sorts of research we did and the questions that we asked in these different buckets of formative audience research, audience segmentation research, and dissemination effectiveness research. So now I'll walk through each one of these and drawing from examples of the work of colleagues and myself. So first, formative audience research is what it sounds like. It's just to generate data. It's often very descriptive research to inform the design of dissemination materials and how they are distributed. So really just understanding your target audience, who you want to disseminate to, better. And there are a number of things that you can assess in these sorts of studies, and I'm going to provide a bunch of examples from our work. So one, you might want to assess awareness of an evidence-based intervention or intervention materials to kind of assist with the implementation of that intervention. And also, I think there's value in assessing awareness about the problem that the evidence-based intervention you're interested in addresses, right? So if an audience doesn't perceive an issue as a problem worthy of some sort of intervention to do something about, they're less likely to be apt to kind of get on board with an intervention to address something. So here's an example. We did a big survey of 475 U.S. state legislators back in 2017, and we asked a whole bunch of things, and I'll present a bunch of data from the survey. But one of the things we were interested in were the extent to which state legislators thought that these 4 different adverse childhood experiences were risk factors for mental health and substance use issues in adulthood. So there's a very strong evidence base showing that each of these 4 ACEs are pretty strong risk factors for mental health and substance use issues in adulthood. And we wanted to see the extent to which legislators really knew that or believed that. So we asked them, and just here you see the breakdown. These are 5-point Likert scale variables dichotomized. But you see, for child sexual abuse and physical abuse, more than half of legislators perceive them as major risk factors, but a much lower proportion in terms of witnessing domestic violence as a child and childhood neglect, despite the fact that there's a strong evidence base showing that those ACEs are pretty major risk factors. So just an example of how we've thought about this. Also, assessing in this phase of formative audience research, a population's attitudes towards the intervention. So what do they think about the thing? So not as much as a knowledge question, more of an attitude question here, more kind of effective. So here we found that it could be useful to use kind of some of Everett Rogers' constructs from his diffusion of innovations theory. So things like relative advantage, the perceived complexity of the intervention, the degree to which it's trialable, and things like that.
There's more.
So this is another example from this survey of state legislators we did. So this was a R21 that was funded by NIMH. And the focus kind of intervention, the thing here was state behavioral health parity laws. So that was the evidence-based intervention that we were interested in. Somebody's not muted. There's a loud sound. The reason that we picked that intervention was that it was funded by the U.S. Community Preventative Services Task Force. So it is kind of at that bar of being as close to an evidence-based policy as you can be. So we asked about a lot of different attitudes towards the law itself. We thought we assessed whether they thought that the law had access to behavioral health treatments. We asked whether they thought the laws could increase insurance premium costs. And because what behavioral health parity laws do, sorry, I should have defined this, these are state laws that require health plans sold in the state to provide equal coverage for mental health and substance use services equal to those for physical health services. Because parity laws increase access and coverage for behavioral health services, we also wanted to get a sense of the degree to which this population, our audience of focused state legislators, thought that mental health and substance use treatments were effective. These percentages were kind of surprising to us, how low they were, and a large proportion of legislators not thinking that mental health and substance use disorders necessarily can be effective. So also, thinking in the policy context, we think of support for a policy as kind of corollary to adoption of that policy. So in the standard D&I study and D&I lingo, adoption is a construct which is defined as doing the thing that you care about, implementing and doing the evidence-based intervention regardless of the fidelity with which it is implemented, or planning to do the thing. That's the construct of adoption. In policy-focused research, because having a law be introduced and then voting yay or nay, it's so complex and there's so much going on behind all of that. We see, whether or not a policymaker supports a policy as kind of a good proxy and way to measure adoption. So that was our main outcome of interest in this survey of state legislators. We asked them to what extent do you agree, do you support state behavioral health parity laws? Of course, we gave a very clear and layman's definition of what those were. And then here, these are examples. We dichotomized that as whether or not they said 4 or 5 on this 5-point scale. And then we looked at these different attitudes and the extent to which they were associated with support for this evidence-based intervention. As you can kind of see, things go the way we would expect in terms of those attitudes I previously presented. If they had more stigma towards people with mental illness, they were less likely to support these laws. And then we see liberal ideology. If you were liberal compared to conservative, you had significantly higher odds of supporting these laws. But I think, an important finding here is while like the 95% confidence intervals overlap, the association is stronger around this attitude that parity laws increase access to behavioral health treatments. And all of these models are mutually adjusted. And this just kind of signaled kind of a potential bright spot and a promising finding in the sense that, of course, ideology is associated with pretty much everything in the policy realm, and we found that empirically. But this suggests, if we could maybe shift legislators' attitudes and knowledge about what behavioral health parity laws do and the strong evidence base indicating that they do increase access to treatments, we might be actually able to cultivate support for this evidence-based policy across the ideological spectrum of legislators. And lastly, in this stage of formative audience research, getting some really concrete information about your audience's preferences for receiving information about the intervention. So like, what do policymakers want in a policy brief? What sources do they turn to? What sources do they trust? What modes of information delivery do they prefer? So do they want webinars, or do they want PDF summaries, or do they want something mailed to them in the mail? And to what degree do their preferences vary? Things of that nature. So very descriptive kind of market research, if you will. This is just an example from that survey of state legislators. We also surveyed state mental health agency directors over on the executive branch side of government in this study. And these are the proportions that said each one of these features of behavioral health evidence, if it was sent to them, is very important. So everything's important. They kind of want it all. Of course, that's not feasible, right? Because they want brevity. They want things to be brief. But they also want all this information. So the real takeaway from this for us was how it provides information on budget impact and cost effectiveness and presented in a brief, concise way are really up here at the top. So signaling the importance of including economic information and evidence in policy briefs and things of that nature. So that's the formative audience research phase. Shifting gears here to this thing called audience segmentation research. And we did not make this up. This is common practice in marketing and advertising and health communication. So the goal with audience segmentation research is to understand how dissemination materials might be tailored for different subgroups within a larger target audience. And this is, standard practice, as I said, in marketing and health comm, research and practice. And the general idea, the premise is that, members of a population are heterogeneous in their knowledge and attitudes and behaviors related to an issue. Thus, audience segmentation research is really an analysis approach to identify discrete subgroups that have similar characteristics. And then the whole so what of this is thinking about how you can tailor dissemination strategies for different subgroups within that larger audience. And the idea being that, these tailored strategies are more effective than one-size-fits-all strategies. And a pretty strong body of communication science literature supports the benefits of tailoring. So there are two broad ways of going about audience segmentation research: demographic separation and empirical clustering. And I'll give an example of both of those. So in demographic separation, you just take your target audience and you take your variable of interest. Here it's attitudes or knowledge about the extent to which legislators think that these 4 ACEs are risk factors for adult behavioral health conditions, and you stratify your data by some demographic characteristic. So here we stratify by the ideology of the legislator, and we see these these significant and graded relationships with liberals being more likely to identify each one of these ACEs as a risk factor than conservatives. This sort of research is kind of useful because it signals, one of two things. Maybe one, evidence about ACEs as risk factors for behavioral health conditions that's reaching liberal legislators, or maybe liberals more broadly and not conservatives. Maybe that's what's going on. Or maybe it's that, conservatives are not persuaded by this evidence. It's reaching them, but they're not being persuaded by it. We don't know which one of those it is from a study like this, but it does signal that there are differences, and thus those differences might be important to consider in dissemination efforts. So that's a demographic separation approach. A slightly more sophisticated approach are these empirical clustering approaches to audience segmentation. So I'm going to give an example from our survey data from state legislators, again, where we try to identify different segments of legislators that have different knowledge and attitudes and legislative behaviors related to behavioral health issues. So we had no plan of doing this analysis when we wrote the grant and when we started our analysis and we're collecting our data. I was just poking around the literature, and I found a really cool study from the field of public communication around climate change, where they did this big survey of about 4,000 U.S. adults, and they did this study, and they called it the 6 Americas, and they found that there are 6 different segments of the U.S. public who vary in how they think about climate change. So I reached out to the first author and lead of that study, who's a communication scholar at George Mason. His name is Ed Maybach, and kind of got a sense of whether or not we could use our data to do something similar. And he said, yeah, you could do that. That makes sense. So I guess the whole point of the reason I'm saying that is, it's so, especially in the field of D&I research, there's so much value of just pulling from all sorts of different disciplines and different analysis techniques and thinking about ways of using data. So I'll walk you through this study in more detail than I've walked you through the other stuff. So just a little bit more about the survey. I've mentioned many times, this was done in 2017. We contracted with a survey research firm to bother the heck out of these legislators. We limited this to actual state legislators. All the recruitment material said we want you, the legislator, not your staff, to complete the survey. Staff are very important, but really we wanted the information from the horse's mouth, if you will. We really wanted those opinions of the legislators themselves. So we did everything you could do to get these legislators to complete the survey. We bothered the heck out of them. We post-mailed them stuff. We called them. We emailed them stuff. And we got a response rate of 16.4%, which at first really bummed us out. We were hoping for higher. Then we looked at the literature, the more recent literature about response rates from legislators. This was way higher than anything anybody's gotten in the past 5 years or so. But a strength was that, we knew about respondents and non-respondents in terms of their political party affiliation, their gender, and their state, and thus their region. So we were able to see how different respondents and non-respondents were. They weren't terribly different. The differences were significant because the N was really big. But we were able to calculate and apply non-response weights to account for the fact that this sample was slightly more Democrat than Republican, that being the main difference. So we use latent class analysis as our empirical clustering technique. That's one that's often used. There's also k-means clustering that also can do the same thing. And then, we ran the analysis. Every person in the sample is assigned a probability of belonging to one of these latent classes that emerges from the analysis. And then we did multi-level logistic regression to identify predictors of segment membership. So, if we trying to get the best sense of if we pick some random legislator in the U.S., some state legislator, and all we knew about them was their state, their gender, and their political party affiliation, what segment would they have the highest probability of belonging to? So 3 audience segments emerged from our analysis, and latent class analysis, whether done in kind of an audience segmentation way or for any reason, is kind of this fun process that's mixed methods in the sense that it is a highly quantitative exercise to analyze these data and identify the segments. But then there's this qualitative exercise of making sense of the quantitative data and naming your segments in a way that captures the most salient features. So we have these 3 segments, and we named them the budget-oriented skeptics with stigma. This was the largest group of state legislators. Passive supporters, and then action-oriented supporters. And I'll talk you through about why we named each one of these as we did, and the most salient attributes of each one of these audience segments. So on the left here, we have these are the variables that we put into the latent class analysis for this audience segmentation study. So these 2 variables I mentioned before about the extent to which legislators thought that mental health and substance use disorder treatments could be effective. we asked 4 items about mental illness stigma that have been widely used in the general public. We calculated a score for every legislator and then put them on a quartile that corresponded with their score. We asked them about a range of factors that influence their support for a behavioral health bill when it's introduced. And the 2 we pulled out to put into this LCA that we thought were really important were the extent to which a bill was going to impact the state budget and the extent to which a bill was based on scientific evidence. And then we gave them a list of about 19 different issues and said pick the 3 that are the top health issues for legislative action in your state. We categorized legislators according to whether or not they picked mental health or substance use. And then we also asked them whether they ever introduced a bill on mental health or substance use. So first is this largest group. So this group is budget oriented because above and beyond legislators in the other 2 groups, this group cares the most about the extent to which a bill is going to impact the state budget when deciding whether or not they're going to support a bill, a behavioral health bill, that is. This group is the most skeptical about the potential effectiveness of mental health and substance use treatments. As you can see, these percentages being way smaller than those of legislators in the other segments. And this group also has the most stigma by far towards people with mental illness. Then we have this group of action-oriented supporters. They are action-oriented because these are the ones introducing mental health and substance use bills in their legislature. Not surprisingly, they also think that these issues are important. And this group also says they care about evidence more than they care about the extent to which a bill is going to impact the budget. Which is a good thing, right? So if the legislators introducing the bills and writing the bills care about evidence, or at least they say they care about evidence, that's promising. And then finally, we have this group of passive supporters. They're passive because they're not introducing bills to address these issues. They also care about evidence, like the action-oriented supporters. But really the most salient feature of this group is that they have a lot of faith in the potential effectiveness of mental health and substance use treatments. So the so what of all of this is thinking how we might tailor dissemination materials and strategies for legislators in these different groups. And you can just think, I won't talk through that in depth, but for this group of budget-oriented skeptics with stigma, obviously, including information about budget impact and cost effectiveness, maybe trying to craft some persuasive messages about the effectiveness of mental health and substance use disorder treatments. And, we could potentially try to reduce stigma towards people with mental illness and also substance use disorders. But at a minimum, we should be really careful not to amplify stigma when communicating with this population of legislators. These other 2 groups, while quantitatively they were distinct and they were separate groups, you could probably disseminate to these 2 groups in the same way, emphasizing evidence and things like that. Because this group says they care about evidence, so let's give them what they want and not gloss over the evidence base for a potential policy that could be introduced to address behavioral health issues. So finally, the final stage, dissemination effectiveness research. So here, this is, the real goal is to determine which dissemination strategies are more effective than others. So randomized control designs, testing dissemination strategy A versus B versus control, and looking at outcomes to seeing really what works best. So what are the outcomes of a dissemination effectiveness study and how may you measure them? So things like attitudes or perceptions of appropriateness, acceptability, or awareness, did you change their knowledge? Those would all be great outcomes to assess. A downside there is, the reliance on survey data, and especially with legislators, it can be tough, obviously, to get a strong response rate. Also, adoption or intention to adopt an intervention, so do the thing or plan to do the thing. Of course, survey data can give you that, but there are a lot of ways that you can unobtrusively get a sense of the effects of different dissemination strategies. Sorry, hold on 1 second. I need to sharpen this pencil for Theo here. In early COVID, I would have been, this is unprofessional, I cannot do this, but at this point in COVID, sharpen the pencil, hand it back to the child. There you go. So, looking at ways that you can assess dissemination outcomes by observing what people do instead of asking them what they do or what they think. So, really proximal outcomes are things like engagement with the evidence, so opening an email or clicking links within an email. In the policymaking space, analyzing artifacts of a policymaking process. A lot of what legislators do is on the books. So looking at their public statements and legislative committee reports, and really specifically looking at differences across the study arms. If a healthcare practice population is your population of focus, you could look at things like claims data across the different study arms to get a sense of whether or not your dissemination materials had an effect on what they did and the sorts of healthcare procedures they performed. So this is an example from our work. So this is a cluster randomized controlled evidence dissemination effectiveness study that we're doing with state legislators. So here again, the focus is on evidence about adverse childhood experiences and behavioral health. So we have 3 different groups. We have this enhanced intervention where every legislator is going to get a policy brief that contains evidence about adverse childhood experiences at the state level, so in their state, so it's tailored for the state, and also includes economic information about the impact of ACEs on public systems. Then we have this other non-enhanced intervention group where the ACE data is still tailored for the state of the legislator, but we remove that economic component. And then we have this control group, which also doesn't have the economic information. And here the data about ACEs at the national level as opposed to the state level. So this will really give us a sense of the extent to which, tailoring evidence and data at the level of the legislator among their constituents has an effect, and also the effect of including this cost effectiveness information. So we're going to send them these one-page policy briefs by email over the course of 1 month, once every week. And then we're going to observe what they do. So things like email open rates, click rates, things like that are outcomes. We're also going to look at what goes on in state legislatures around adverse childhood experiences and compare differences in things like bills introduced or tweets about the issue across the study arms using this database called Quorum. And then finally, we're going to do a survey to assess attitudes and knowledge and things like that. The survey is kind of like, they're really important information, but we're thinking of them more as tertiary outcomes because, the response rate issue is so challenging. We're not holding out hope for an amazing response rate, especially in the COVID context where these folks are working more remotely than they usually are and are also legitimately busier than they normally are and probably less likely to really get on board with evidence about a new thing. But we will find out. So shifting gears in this last little bit of the presentation, then we hopefully have some time for questions and discussion. So policy implementation research. So again, dissemination being more about the spread of information to change knowledge and attitudes and really thinking about that as communication, whereas implementation is more about changing behavior and changing practice and changing what goes on kind of on the ground as opposed to in the heads of people. So this is just a great article that was written a little while ago now, but if you're interested in policy implementation research, this is a great article. So in the field of political science, and more specifically this subfield of policy science, they've been studying policy implementation for decades. And then in the health dissemination implementation space, policy implementation research is really understudied and kind of this new thing. So in this article, they kind of point out the similarities and the differences between policy implementation research as conceptualized and studied in the D&I and health space and the political science space. And I think the main real difference is that in the political science space, and no, this isn't a criticism of the field in any way, but, the goal is to understand the phenomenon and put it out there and describe it and really capture the phenomenon, without necessarily an eye towards intervening on that phenomenon and doing it better and changing something. Whereas in D&I and health research, that is core to every study. So every study has some, even if you're not testing something, the so what and the whole reason to do a D&I study is to intervene on something and make the thing more aligned with evidence and thus better for more people, right? So in D&I, there is this practice element that is so integral to every study, where in the political science, policy, implementation research, that can be there, but it's not always there in the same way. I just want to call out this other article led by a great team at WashU. They did this really big systematic review of quantitative measures of health policy implementation, which is, I think, a really important paper because here, they pull out really concrete tools about how to measure, quantitatively at least, the implementation of health policies. So I just want to highlight a couple different ways of thinking about policy implementation research or examples of policy implementation studies. So one, you can do a study to describe the process through which a policy has been implemented. So, doing interviews, surveys, asking people about this policy that was passed and implementation was supposed to begin, let's say, 2 years ago, and just kind of getting a sense of how's that been going? Why do you think it's been going the way it's been going? And with that, you might start to get some sense of how that process might be improved. And in that, doing things like identifying policy implementers, perceptions of the degree to which a policy has been enforced or is being adhered to. I think this is also really important for policy impact studies. These sorts of studies are often conducted in health services research and in the field of health economics, where, the independent variable is the passage of some policy, the dependent variable is some health outcome, but often it's kind of like this black box. They don't really measure or study the degree to which the policy on the books was adhered to or enforced, or let alone policy implementers' perceptions of that. So I think there's a lot of value in getting that information from policy implementers. Getting ideas about the barriers and facilitators to policy implementation. You could also assess in a study like this the acceptability and feasibility of different policy implementation strategies. So, for example, you might have this idea that you're going to train the policy implementers about how to implement this policy better, right? So help improve their knowledge, maybe develop some skills, things of that nature. And first, you might want to get a sense of whether or not the policy implementers are on board to do that and whether or not they think that would actually be feasible and is something they'd like to do, or even would do with a degree of fidelity if they had to do it. And finally, you could test different policy implementation strategies to determine which are more effective than others at improving both implementation and effectiveness outcomes. So these sorts of studies are done in clinical implementation science research all the time, but you could do the same thing in a policy implementation setting. The kind of the limiting factor being, you have to, and you could do this. You could think of policy in many ways, right? So it could be health system policy. So you could randomize health systems to different implementation strategies, but I think often it's public policy at some jurisdiction level, state or local. So you're kind of limited by the number of states, for example, that you could randomize, but within that you can have a bunch of different people and test different implementation strategies. So lastly, kind of to conclude, thinking about areas for policy D&I methods innovation, and I think really just, future research more broadly, even beyond methods innovation particularly. So, and I think thinking about this, there's policy making processes, then there are the policies themselves, which are the statutes and the rules and regulations that are codified and are written down and are publicly available. And then there's policy implementation, how those policies actually get rolled out. And I think, policy dissemination research fits in well to the policy-making process, right? Because you want to get evidence into the process. You want to get it into the bills. And to do that, you can change policymakers' knowledge and attitudes around different issues and evidence-based approaches to addressing issues. And then, in terms of implementation, of course, that's where this policy implementation research is probably better suited than dissemination research. And I think even if, in your D&I research, if policies aren't your focus, if you are focused on clinical or organizational settings, there's still a lot of value in thinking about policies as that outer context factor and how policies might impact the clinical behaviors that you're really interested in. And ideally, a sequence would look like this. You could do good policy dissemination research. You act on those findings. You infuse research evidence into policy-making processes, which then gets codified in the policies themselves. And then, the policies are implemented. Then you do good policy implementation research, learn how to best implement the policy. And then, in an ideal world, there's this feedback loop where that evidence, those kind of guidance for how to implement a policy well, gets into the policy-making process itself. So when a bill is introduced and written and then potentially passed, it has very concrete language about policy implementation and how to use different implementation strategies to enhance things like enforcement and adherence with the policy and things of that nature. So with that, I'll conclude. I have a handful of minutes, about 13 minutes for questions and discussion. So thank you for listening.
Thanks so much, Jonathan. That was wonderful. Definitely a lot of information. So yeah, definitely would like to open up. We have about just under 10 minutes if anyone has any questions.
Yeah, hi, Jonathan. This is Lee Pachter. How you doing?
Hey, Lee. How are you?
Good, thank you. I have a question. First of all, it was really very interesting. The work that you're doing is mostly on an individual policymaker level, and I'm wondering whether there's multi-level approaches. Because, for example, a liberal, legislator in the People's Republic of Vermont may have certain ideas, but if he's in a purple state, they might act differently. So is there like an ecological level that you could also add into these analyses?
Yeah, absolutely. And we've done that a little bit. So in the one study where our main outcome was support for state behavioral health parity laws. So right, our main outcome, it was this individual level thing, whether or not the legislator supported that. But we did think about it more in an ecologic way. So we brought in a bunch of state contextual data for every legislator. So for example, we brought in information about, the opioid overdose death rate in the state. We brought in data about unemployment, the idea being that if unemployment is higher, legislators would be less likely to support anything that would potentially impact the economy, and a range of other kind of state-level variables, and kind of link them up with the legislators. So yeah, absolutely, and I totally agree with you. It's critically important to consider the context in which these legislators are operating. We use state fixed effects, so that's like a quantitative thing we did in our analyses. But we could definitely do it better, because I totally agree with you. Right? And also what it means to be conservative in Vermont is different than what it means to be conservative in Wyoming, right? So it's kind of with these individual level data, especially things like ideology, it is kind of apples and oranges, but between the states, because the context colors those responses so much.
Great, thank you. Perfect.
Hi, Jonathan, can you hear me? This is Scott.
Yeah. Hi.
Hi, thank you for the talk. This is great. And I'm a psychologist, so this is particularly relevant to my work. One question I had is if you've given thought to when you're dealing with people who are budget-minded on the dissemination side, one approach is to show evidence that suggests whatever policy we're going to implement may not be as budget detrimental or may even help the budget, right? That's one way, is to take a fiscal approach to persuasion. But I've become concerned that sometimes when we do that, we constrain what we can really do on the clinical side. So we'll support interventions that may be cost saving, but we're then implicitly devaluing interventions that might improve people's quality of life, but would still cost the state more money. You could have a separate argument about whether that's a good way to spend money. We're going to improve people's lives. Not everything has to be cost savings. So I've seen this play out in a number of settings, and I just wondered if you've done any work on this or thought about it.
Yeah, totally. We've absolutely thought about it, and we've done a little bit of qualitative work, really just exploring the exact issue that you raise, right? Because it can seem like really crass, for lack of a better term, to just tell a story in monetary terms and kind of not acknowledge the fact that improving people's lives is an outcome we want to promote in and of itself. So the only way we've really looked at this in the messaging about adverse childhood experiences study I mentioned, there was a qualitative portion of that where we interviewed about 25 different policy advocates around adverse childhood experiences, focused on their communication strategies. And we asked them about different ways of framing ACE evidence. And one of them was, what do you think about this economic argument? And yeah, they kind of said, it can be really effective, especially with conservatives, to pique their attention. But it does have this downside as kind of like depersonalizing, really important issues that we should address as a society, regardless of whether or not they save money.
Thanks.
David, I see your hand is raised. We figured out how to raise hands. Do you have a question?
Yes, thank you so much for this talk. I was very excited to hear it. I've been following some of your work related to firearm violence and policy and prevention. And my question is more of a philosophical one in that regard, with the polarization that's often present and often the questioning of the value and validity of evidence that can be introduced through that politicization process. How do you decide in terms of your approach to even phrasing the recommendations for policy and making those kind of selections, particularly if you also have either yourself or members of your team that are involved with direct advocacy related to interventions that they do believe to be particularly effective?
Cool. Thanks for that. Sorry, the younger one, the 2-year-old, busted in pantless in the middle of that question, and the wife was chasing him. So I got a little distracted. I got very distracted, actually. So I'm sorry. I mean, the polarization is huge. So I'm going to speak to polarization because I heard that word. I'm sorry I didn't get your whole question. And then also what you said about when you're working with advocates. I'll just kind of share a thought about kind of the where advocacy sits in policy, where I see it sitting in policy focused D&I research. So, I mean, in terms of the polarization, we've thought about this a lot, especially in terms of these quote unquote boomerang effects, whereas, you give evidence to somebody to counter a belief they already have, and you kind of say, actually, no, you're wrong. Here's the evidence showing that it's actually this way. The boomerang effect is when that is counterproductive, and they support the thing you want them to support even less than they did before because you presented this evidence that was contrary to their a priori notions. So that's one thing that we've worried about. So, thinking about, if we're disseminating evidence about adverse childhood experiences to some conservative legislators who are maybe, really distrust the academy and universities and science produced from universities, are we going to have any unintended consequences in our communication? Which we're not worried about that enough to not send evidence to them. But it has definitely crossed our mind, and something we want to try to observe the best we can. Just in terms of advocacy and kind of D&I, policy-focused D&I research, so I was interested in this area of using empirical research methods to figure out how to better get evidence into policymaking. And I started my tenure track position at Drexel, and really I knew I had to get some grants to get tenure and keep my job. So I wanted to study this, but I really didn't think that NIH would fund this work because they would think it's too close to advocacy, right? My concern was that NIH, a federal government entity, is not going to fund research to help researchers influence what states do. I was afraid that they might say, cool, but we can't fund that. We just can't do that. That's advocacy. But when I spoke to a program officer at NIH and then multiple program officers, I was very relieved and also surprised to hear that no, what you're doing is not advocacy. And it's not advocacy in our book because what you're focused on is evidence. Everything you're sending to these folks and the knowledge and attitudes you're trying to change are all aligned with some sort of fairly strong empirical evidence base. So this is about getting real facts out there in terms of what NIH would consider facts, as opposed to promoting an agenda that is perhaps potentially could be less aligned with evidence. So I don't think the two are mutually exclusive. I mean, I want to see better policies to help kids and families and prevent ACEs, regardless of whether or not, I want them to be evidence-based because I think they're going to work. But, I would consider myself an advocate for those issues. But in this sort of research, as long as, you're really pushing out evidence and not a particular policy position that's not aligned with evidence. NIH at least, and I think I feel comfortable with it too. Like it's different than advocacy. So I'm sorry if I didn't really answer your questions because of the interruption, but yeah, some thoughts on things you mentioned.
It's definitely the new normal, Jonathan. I think we're all used to
Yeah.
that. Humanizes all of us. I think we have time for one more question, if anyone had anything they wanted to raise. If not, I have a question. Let's check the chat. Again, thanks so much, Jonathan. This is really fascinating stuff. I know that de-implementation is a growing field. Do you know of any work being done specifically? What would that look like in the policy space, I guess is my question.
Yeah, totally. Yeah, that's a great question. So there's been some work. I don't think it's published yet. I was on the dissertation committee of a student who got her PhD from Washington University in St. Louis, and her work was focused on the de-implementation of school-based obesity policies that do not have a strong evidence base. So I guess there's a lot of activity in the space. A lot of states have passed laws to address youth obesity via various school interventions, and a lot of them don't really work. So her analysis was really focused on legislation, so analyzing the text of legislation over time, amendments to bills, and kind of the de-implementation, but kind of more on the books than in practice. So that's one way it would look like. A more hands-on way of looking at it with like more primary data collection would be, yeah, a law passes to de-implement a bill, and you go to that place and you talk to people about how that's been going. This isn't exactly your question, but it jumps to mind. So we recently did a survey of state and county substance use agency policymakers, and we asked them a bunch of things, and one of the things we asked them was to rate the extent to which like 15 different youth substance use issues were priorities for their agency. So they rated these 15 things on a 5-point scale, and one of the things we asked about was, to what extent these policymakers perceived de-implementing non-evidence-based youth substance use disorder treatments and prevention strategies as a priority. So do they prioritize de-implementing stuff that doesn't work? And nobody cared about it. That was way down at the bottom, like by far, of the priority list. And to us, that's interesting, and this resonates with what you said. In the field of D&I research, there's a lot of excitement and hype about de-implementation and that being this really important thing. Maybe it is. But just our data showed that, well, maybe D&I researchers feel that way, but these particular policymakers do not agree. And I think it's because at the top of the priority list was increasing treatment and program capacity. So we kind of interpreted the data as being like they need more, there's more demand for services and more need for programs than what they have. Thus, it makes sense they might be less likely to take something away. Even though it makes sense you have to take something away to put something new in oftentimes, I think they just like the idea of taking stuff away doesn't make sense because right now they just want to get more out there.
That's really interesting. And yeah, maybe it definitely is a very of interest for the researchers in the field, and I perceive definitely a lot of potential opportunities in the healthcare system space.
Yeah.
In terms of looking at the implementation. Yeah.
Yeah.
Well, thank you so much, Jonathan. This was really, I'm so glad we could coordinate this so you could be able to come and speak with us, even though it was virtual. Really appreciate it. And yeah, thank you.
Thank you for having me, and thanks for the nice questions and discussion. Bye.
Bye. Thanks, everyone.